Welcome to the deep dive. Today we're tackling a really important piece of medical detective work.
Yeah, we're looking at how we treat those, well, troublesome blocked arteries in the legs.
The ones doctors call symptomatic femoropopliteal artery lesions.
Exactly.
Think of it as us going behind the scenes, really understanding the evidence that shapes treatments people get for this condition.
Precisely. We're going to explore a key study. Durable clinical effectiveness with Paclitaxel Eluting Stents in the Femoropopliteal Artery. The 5-year results of the Zilver PTX randomized trial.
Okay.
This was a big one, published in Circulation back in 2016. Dr. Mark Dake was the lead author with the Zilver PTX investigators.
Right, so what was the core question? What problem were they trying to solve with this big study?
Well, the fundamental question was whether using stents coated with a drug called Paclitaxel PTX for short would actually work better.
Better in the long run.
Yes, better for keeping these leg arteries open compared to the standard approach, which is, just using a balloon to open the artery. Angioplasty.
PTA.
PTA, yes. Or sometimes, if that didn't work well enough, maybe putting in a plain bare metal stent.
Okay, and why should this kind of deep dive into vascular treatments matter to you listening right now?
Well, look, if you or someone you know is having pain, maybe difficulty walking because of reduced blood flow in the legs, that's peripheral artery disease, then understanding how well different treatments actually hold up over time is really vital. This study looked right at that long-term effectiveness for a specific approach.
So it helps make informed decisions.
Exactly. It's a key factor.
Okay, let's get into the study design then. Sounds like it was quite detailed.
Oh, it was. The Zilver PTX trial was prospective, multinational, a randomized controlled trial, an RCT.
The gold standard.
Right. That's how we try to compare treatments fairly. They enrolled patients who had, symptomatic blockages in that main artery above the knee.
And these patients had specific characteristics.
Yes, they had leg pain when they exerted themselves a certain level, Rutherford score, Q2, and reduced blood flow measured by the ankle brachial index, or ABI, less than 0.9.
Okay.
Their blockages weren't super long, 14 centimeters, but narrowed the artery by at least half. Vessel size had to be right, 4 to 9 millimeter, and crucially, they needed at least one good runoff vessel further down the leg.
And make sure blood could still get to the foot.
Precisely. So yeah, quite specific criteria.
Right, a very defined group. So what happened after they identified these patients?
Okay, so the researchers randomly assigned them to one of two initial treatments. One group got a primary treatment with a self-expanding stent coated with paclitaxel, that's the drug-eluting stent, or DES.
Got it.
The other group started with PTA, percutaneous transluminal angioplasty, using the balloon to open the artery.
Okay.
Now, here's where it gets a bit more nuanced. If that initial PTA didn't work well, maybe the artery dissected or recoiled.
It failed, basically.
Yeah, an acute failure. Those patients were then randomized again.
A second randomization.
Yes. They either got a bare metal stent, BMS, or they received one of the Paclitaxel Eluting Stents, the DES. This was the provisional stenting part, sort of a backup plan if the balloon alone wasn't enough.
Okay, that makes sense. So you had the group getting DES right away, and then this other group starting with PTA.
The standard of care group, you could call it.
Right, standard of care starting with PTA and maybe getting a BMS or even a DES if that first step failed. So what were the researchers tracking? What were the key outcomes?
The main things, the primary endpoints, were primary patency and event-free survival. And they looked at these at 1 year and then again at 5 years.
Okay, define those for us. Primary patency.
Primary patency basically means the treated artery stayed open and didn't need another procedure to reopen it during that time.
And event-free survival. Sounds serious.
It covers major adverse events, things like, unfortunately, death, amputation of the limb, needing another procedure on that same treated spot because of symptoms.
Clinically driven revascularization.
That's the term, yeah. Or severe worsening of blood flow needing surgery, or just a really significant decline in their condition related to the leg. So yes, pretty serious outcomes.
Definitely significant measures.
Yeah.
How many people ended up in the trial?
It was a good size, 479 patients altogether across 55 centers, U.S., Japan, Germany.
Wow, international.
Yeah. 241 were in that primary DES group, and 238 started in the PTA group. Now, of those PTA patients who needed that backup stent, 120 did.
Okay.
59 of them got the bare metal stent, the BMS, and 61 got the drug-eluting stent, the DES. And like you said, they plan to follow everyone for 5 full years. Long-term view.
And just to be crystal clear, who wasn't included? Any key exclusions?
Sure. They left out patients with major blockages further up the leg, inflow disease, because that could mess up the results.
Right.
Also, if the specific artery segment they were looking at had already been treated before or already had a stent, those patients weren't eligible. And those specific lesion characteristics we talked about, length, narrowing, artery size, those were strict inclusion points.
Got it. Okay, so a well-defined study group and process. Let's get to the results. After 5 years, what did they find? Did the PTX-coated stents show a clear benefit?
Well, yes, the results were pretty consistent, actually. The DES group generally did better than the group that started with PTA, even when you factor in the provisional stenting in that second group.
Okay.
At both 1 year and 5 years, event-free survival was significantly higher for the DES patients, 81.4% compared to 70.1% at 5 years.
So fewer major adverse events in the DES group.
That's what it suggests, yes.
Yeah.
A greater proportion avoided those serious issues.
That's a noticeable difference. What about keeping the artery open, the primary patency?
Yeah, another big difference. The primary patency rate at 5 years for the overall DES group, remember, that includes initial DES and provisional DES,
Right.
was 66.4%. Compare that to just 43.4% in the standard of care group. That's the optimal PTA plus a provisional BMS if needed.
Wow, okay, so 66 versus 43%, that's quite a gap.
It is. It tells us the arteries treated with the Paclitaxel stents were, much more likely to stay open long-term without needing another fix.
Were patients also less likely to need repeat procedures on that specific spot?
Absolutely. That's freedom from target lesion revascularization, or TLR.
Freedom from TLR.
Right. That was also significantly better in the overall DES group. 83.1% versus 67.6% for the standard care group at 5 years.
Okay.
And what's quite interesting, even if you just look at those patients who needed a provisional stent after the initial PTA failed.
The head-to-head comparison within that subgroup.
Exactly. Even there, the provisional DES outperformed the provisional BMS. Both for keeping the artery open, primary patency was 72.4% versus 53%. And for avoiding repeat procedures, freedom from TLR was 84.9% versus 71.6%.
So the drug coating seemed to make a difference, even in that backup scenario.
It appeared so. Overall, the study concluded that using these DES cut the relative risk of the artery re-narrowing, restenosis, and needing another procedure, TLR, by over 40% at 5 years.
So, based purely on this study's findings, the Paclitaxel Eluting Stents look like a significant step up.
Yeah.
But, every study has its nuances, its limitations. What should we keep in mind here?
That's a really important point. Absolutely. While Zilver PTX was, a landmark trial, first big RCT with long-term follow-up in this space,
Yeah.
it wasn't perfect. For one thing, the design didn't directly compare putting in a DES right away versus putting in a BMS right away.
So no primary DES versus primary BMS comparison.
Correct. We saw DES was better than the PTA first strategy, which often ended up with a BMS if it failed. But we can't say definitively from this study alone that the drug coating was the sole reason for the benefit compared to just using a bare metal stent as the first choice.
Okay, that's a key distinction. Were there other treatments available then or emerging that weren't tested here?
Yes, definitely. The trial didn't look at other technologies that, are used quite a bit now, like drug-coated balloons, DCBs.
Right, balloons that deliver the drug without leaving a stent behind.
Exactly. Or atherectomy devices, the ones that actually remove the plaque. Those weren't part of this comparison.
And what about patient follow-up? 5 years is a long time.
It is. And like many long studies, they did have some patients withdraw or get lost to follow-up. About 6.4% per year, which, you have to account for that potentially impacting the results somewhat.
Okay. And the patients themselves, you mentioned specific criteria. Does that affect how broadly we can apply these findings?
That's a critical question, absolutely. The vast majority of patients here, about 91%, had claudication.
Leg pain with walking relieved by rest.
Right. Not the most severe form of the disease, which is critical limb-threatening ischemia. Only a small fraction had that.
Wow.
And also, the blockages they treated were relatively short, on average just over 6 centimeters.
Okay.
So you do have to be a bit cautious applying these results directly to patients with much more severe disease or those with really long, complex blockages. Their outcomes might be different.
So this built on earlier work you mentioned. What was the landscape like before Zilver PTX?
Yeah, it definitely added to a growing picture. The Resilient trial, for example, had already suggested stenting was generally better than just PTA alone for these SFA blockages.
Superficial femoral artery in the thigh.
Right. But we also knew, just from experience, that both PTA and bare metal stents often had problems with the artery narrowing again over time, restenosis.
A common issue.
Very common. So the idea behind drug-eluting tech, which had worked well in the heart artery,
Coronary arteries.
right, was could we stop that restenosis in the legs too? Interestingly, some early attempts with a different drug, sirolimus, on stents in the leg didn't really show a big advantage over bare metal.
Right.
But then studies using balloons coated with the paclitaxel, like Thunder and Levanti, they started showing some promise. Reducing restenosis, reducing repeat procedures.
Okay, so PTX seemed more promising in the legs.
It seemed that way initially, and another trial, Debate SV, also hinted at benefits for drug-coated balloons used with bare metal stents. So Zilver PTX, focusing on PTX eluting stents, was a really significant piece of that puzzle.
It's fascinating how the tech evolves. You mentioned the heart arteries earlier, how things went differently there. What's the story?
Yeah, it's a really interesting contrast, isn't it? While PTX eluting stents showed this promise in the legs, in the coronary arteries, they've largely been, well, superseded.
By what?
By stents coated with different drugs, mostly limus-based drugs like everolimus or zodorolimus. These newer generation coronary stents, they've generally shown better long-term outcomes. Some studies even suggest reduced mortality compared to the older ones.
And that shift didn't happen in the legs?
Not really, not to the same extent. We didn't see that same big move away from paclitaxel in peripheral artery disease treatment, despite its decline in coronary use.
Which is interesting.
Yeah.
And it leads us right into that big controversy that came up after Zilver PTX was published, the safety question around paclitaxel itself.
Yes. This is a really crucial context. In 2018, a meta-analysis came out, where they combined data from multiple studies. And this analysis reported a potential increased risk of death associated with using paclitaxel-coated balloons and stents in the legs in the femoropopliteal arteries.
Increased death. That's serious.
Extremely serious. And understandably, it caused a lot of concern. The FDA issued a warning, told doctors to be cautious, consider alternatives.
That must have really shaken things up.
Yeah.
Were there questions about that meta-analysis itself? Criticisms?
There were, yes. Several points were raised. One big one was the lack of a clear biological reason, a mechanism for how paclitaxel in these devices would actually cause increased death later on. And also, the analysis used pooled data from the different trials, not the individual patient records.
Aggregate data versus patient-level data.
Exactly. And sometimes pooling data like that can kind of smooth over important differences between the studies, the patients, how they were treated.
Potentially misleading.
Potentially, yeah. Or at least making it harder to be certain about the conclusion.
So how did the Zilver PTX team and others respond?
Well, Dr. Dake and his group, they went back to their own data. They did a deep dive into the individual patient records from the Zilver PTX trial.
Okay.
They also looked at data from post-market studies in Japan comparing Zilver PTX to bare metal stents. And their analysis, looking at that patient-level data, found no statistically significant difference in all-cause death between the groups that got the PTX devices and those who didn't.
So their own data didn't show that mortality signal?
Their detailed analysis didn't, no, and other groups have done similar investigations since then. I think that the general feeling now is that we need more rigorous research, ideally using that individual patient data across multiple trials and really trying to understand if there is a biological link.
So the jury is still out, in a way.
It's fair to say the issue requires ongoing investigation. We're just presenting the different findings here, not taking a side in that ongoing debate.
Understood. So let's loop back to the Zilver PTX trial itself. Setting aside the later safety debate for a moment, what was its overall impact? How did it change practice at the time?
Oh, it was definitely influential. It was one of the biggest randomized trials looking at an endovascular device for this artery. And those long-term results showing the benefit of the drug-eluting stent, they were compelling.
How did it help? What was the mechanism?
Well, the stent itself, the nitinol scaffold, it provides that structure, holds the artery open, helps prevent that immediate recoil or dissection you can get with just ballooning.
Right.
And then the paclitaxel, the drug, was designed to stop the cells in the artery wall from overgrowing and causing that re-narrowing, the restenosis, down the line.
And how did these results stack up against traditional surgery, bypass surgery?
That was another really interesting aspect. The 5-year patency rates, how well the artery stayed open in Zilver PTX, were actually pretty comparable to what you typically see with surgical bypass in the leg.
Really? Comparable to surgery?
Yeah. Some even suggested maybe better than using artificial prosthetic grafts in certain cases, which was significant, right? Because It hinted that maybe this less invasive catheter-based approach could give you similar long-term results to open surgery.
So it sounds like Zilver PTX, plus the data on drug-coated balloons, maybe atherectomy. It all kind of pushed towards this endo-first idea.
Exactly. Try the endovascular, minimally invasive route first before considering surgery.
That seems like a major shift.
It was. For a while, the trend was definitely towards using these drug-eluting technologies as the go-to initial treatment for many patients with these blockages.
Wow.
But, as we've discussed, those later safety concerns about paclitaxel definitely put the brakes on that trend. We've seen a noticeable drop in the use of these devices more recently.
So things are still evolving.
Constantly. The way we treat these conditions is always being reassessed as new data comes in, as we better understand the long-term picture, the risks and benefits.
Okay, this has been a really thorough look at one specific but very important study. To wrap it up, what's the key takeaway from the Zilver PTX trial for our listeners?
I'd say the main point is that Zilver PTX provided strong initial evidence that Paclitaxel Eluting Stents were effective for treating these leg artery blockages. It showed better long-term artery patency and fewer repeat procedures compared to the standard approach at the time, which was PTA, often with a bare metal stent backup.
But it's also crucial to remember the context, right? The limitations, the specific patients studied.
Absolutely.
And of course, those later safety questions that arose regarding paclitaxel.
Precisely. Zilver PTX was a big step, but you have to consider who was in the study, what kind of blockages they had, and the ongoing safety discussion just highlight how medicine evolves. Treatment guidelines aren't static, they change as we learn more.
Which leads perfectly into our final thought for you. Given this whole story, the initial promise of Zilver PTX, the complexity added by safety concerns, the constant technological change, how do you personally approach understanding the risks and benefits of different treatments, maybe for vascular conditions or anything else?
Yeah, it's a great question.
We really encourage you to think critically about these advancements and just appreciate how vital that ongoing research is for guiding the best possible care. Thanks for joining us for this deep dive.